So the final talk in this afternoon session is Prehospital Resuscitation in Spinal Cord Injury by Dr. Andres Rubiano from Colombia. Thank you so much for coming this way and talking to us on this topic. Thank you.
Gracias por venir. Well, we're going to be talking a little bit about resuscitation in patients that have spinal cord injury, SCI. When we try to identify epidemiological data regarding the SCI, we see that there are many areas in the world that don't have information as to this type of injuries. We've mentioned this throughout the conference that it is indispensable for us to understand and to look for data, especially in areas where we find the greater number of patients with trauma. Of the little data that there is and that we can identify, and this is part of a worldwide report that was worked on with the World Health Organization a few years ago, trying to find data from different countries so that we could understand the magnitude of the problem and talk a little bit about management. It was important for us to identify that many of these injuries do not present in an isolated fashion, that there are systemic injuries, oftentimes thorax trauma and abdomen. Approximately 20 to 57% of those with SCI have other injuries that typically involve the head or the chest. In the last 10 years, the severity has decreased, and this is especially due to the fact that we have improved pre-hospital management, we have improved surgical care, and because we have improved ICU care. It's quite clear that if this is the panorama that we face, patients that have SCI that are at risk of having greater secondary injuries during the initial care or during transportation. Many patients are going to have hypotension, so we should try to reduce as much as possible in pre-hospital care the possibility of secondary injury. And this, in the pre-hospital environment, represents a challenge if we understand the context within which this pre-hospital care is offered. It's much more complex to do resuscitation within the process, and this is connected even more to the lack of resources and the tremendous heterogeneity that exists in the skills that many of the pre-hospital care providers offer in many parts of the world. In many multi-center studies that we've done with the World Health Organization, we've seen that there are many parts of the world where pre-hospital providers have many deficiencies. In many places, there is no training whatsoever in trauma care. Regarding what we have tried to identify evidence-based care for pre-hospital care, we have done a review of the literature and tried to establish some guidelines. It is very crucial for these patients that we do appropriate airway management and intubation. Airway management in acute SCI patients that require intubation in the pre-hospital setting should include the use of manual inline cervical immobilization. We know that when we do the intubation of patients, we often have to do mobilizations of the neck, and if we don't try to protect the neck within this initial intubation process, we could add another injury or make worse the injuries that already exist. Intubation of patients should not be based solely on cervical collar neck immobilization. Oftentimes we place the collar and we think that we've totally immobilized the patient, and we know that many of these neck collars limit the flexoextension movement but not lateral movement. Indirect methods of intubation that are used could be a good alternative. At present, there are many methods that offer support for intubation with minimum movement. At present, a program has been developed by the Neurological Care Association, which is the Emergency Neurological Life Support. It has a specific area for spine injury. Within these courses, they promote certain recommendations or general parameters for urgent intubation in SEI, and obviously they mentioned that we have to identify the respiratory problem, patients that are already feeling respiratory distress, that this should be done at an early stage, especially at the pre-hospital level. If they can't hold their breath, for example, for at least 12 seconds, which means that there has been a decrease in their capacity. And obviously, if they have breathing that is supported by external muscles, lead us to know that the patient is going to need intubation, so we should do it in an early stage, even at the pre-hospital setting. We had already mentioned that it's very frequent for us to find other traumas associated with SCI, especially thorax, abdomen, cranium. So the intervention, the disruption of sympathetic fibers through injury to the cervical or high thoracic spinal cord will produce hypotension or neurogenic shock, and neurogenic shock is going to be a lot more difficult to manage than just the hemorrhaging shock, which depends on volume. As a general rule, the higher and more complete the injury, the more severe and refractory will be neurogenic shock. 50 to 90% of individuals with cervical SCI require not only fluids, but also vasopressors to maintain a minimum MAP. We should remember that neurogenic shock is handled or managed as a distributive shock, wherein normally the cardiac output is normal, respiration is normal, but there is vasodilation that takes place in a generalized fashion underneath the injury, which leads arterial pressure to drop considerably. And this leads us to lose the tone of the vasoconstrictors, especially in the peripheral area, and the loss of this tone, the hypotension and neurogenic shock will lead us to an inability to redirect blood flow from the periphery to the core circulation. The disruption of the sympathetic innervation to the heart and predominance of presympathetic tone induce low cardiac output because of the impaired cardiac contractility. And so we have a patient that, aside from having hemorrhagic shock and a systemic response that is not collaborating or helping to be able to maintain the mid-level cardiac pressure, which is indispensable for us to guarantee perfusion of the spinal cord. Remember that it is neural tissue, and the same concept that we use to guarantee cerebral perfusion must be used to guarantee medullary perfusion. It's exactly the same. The Trauma Center group in Maryland, headed by Dr. Arabi, who is one of the surgeons there, have demonstrated in the emergency room and in surgery how in MRIs the patients that have their arterial pressure compromised are more subject to ischemia in the medullary region. So what can we do in pre-hospital care management? Obviously, try to guarantee appropriate volume so that we can guarantee venous return. We've done this based on the principles of resuscitation with low volume. We must not overload these patients. We know that the problem oftentimes doesn't have to do with volume, but failure in constriction or the motor response of peripheral vessels. Included in the guidelines, they recommend correction of hypotension in the spinal cord injury with a systolic blood pressure of over 90 millimeters of mercury as soon as possible, including in the pre-hospital setting. Regarding the management of acute cardiopulmonary failure in these patients, well, obviously, we follow all of the guidelines that have already been mentioned. We must keep in mind that it's very difficult to evaluate this medullary perfusion, just like it's sometimes hard to measure cerebral perfusion. It's much more complex to measure it in the medulla because it's very complex to measure pressure within the spinal column. Many studies tell us that improved neurologic outcomes with a MAP greater of 85 to 90 milligrams of mercury. In order for us to understand what's happening to these patients, we have to do a clinical evaluation of their neurological status. The most appropriate clinical evaluation is done through the chart of Asia. Here we evaluate on 5 levels as to whether there is the presence of muscular strength underneath the injury, and if it is equal to or less than 3 on a scale of 0 to 5. It's important for us to train our pre-hospital team so that they can know how to use this scale, because this operates very similar to the Glasgow scale for encephalic trauma. And during the transfer, we can identify whether the patient is increasing or decreasing in his score in the Asia scale. And obviously, damage control resuscitation in SEI is based on balanced resuscitation using the early use of plasma, platelets, until the bleeding is controlled. We know it's going to be much more complex to have good pressures because we will need vasopressors, which is complicated at this stage, but there are some systems that have developed the possibility of using these vasopressors. So what are the lessons that we have learned from the different battlefields? Well, obviously that spinal shock results in a disproportionate hypotension to the volume of fluid lost. If we do a clinical evaluation at the scene as to how much blood the patient lost and basing our evaluation on the ATLS guidelines, it's likely that these patients have suffered much more injury than what we would initially have thought. So we have to be very careful when we're doing the resuscitation. Oftentimes the pre-hospital team tries to increase the volume to sustain arterial pressure that we know doesn't just depend on the volume, but rather requires additional management. So obviously this can lead us to all of the changes that we don't want that have to do with overflow in the resuscitation. It has to be limited to what is required so that we can have detectable radial pulse. All of the work that has been done in battlefields in Iraq and Afghanistan have shown us that one of the most appropriate clinical indicators to know whether the patient has adequate volume or not is to look for the radial artery and look for the pulse. If we can detect it, he probably does not require more volume at the time. We have tried to do studies to search a little bit more evidence in this regard. We haven't made much progress. The groups that are studying this problem the most right now are the basic sciences group in Toronto and the University of Alabama and Miami. They've been working for many years now. as to what medication could help us manage these patients on a pre-hospital level. The best option is to maintain good medular perfusion. There's already some work at present using hypertonic saline solutions to extrapolate the same effect that hypertonic solution produces in the brain. All of the factors that we have to take into consideration to correct or to have a good management of patients that have cranial trauma applied to SEI. As a matter of fact, there are some recent studies that show that early decompression of the medular injury in its osseous part can lead to better results with these patients. What we've mentioned and what we have to bear in mind is that the TBI resuscitation principles apply to SCI in the same manner. We have to avoid overloading with liquids, and it's very basic. We need to have more information. We need to carry out more research in the areas where we have these patients with SCI in the civil environment, because this will allow us to truly be able to identify what management will bring about a positive change in these patients. So let's remember that we need neurotrauma registries. Canada has made quite a bit of progress. National data that they have, the U.S. is also doing it, and it's crucial that we obtain more data so that we can determine which factors influence the management of these patients. Thank you.
Dos preguntas, una personal. ¿Tenés
Personal
idea de
question. Do you know if there's any pre-hospital system that is geo-referenced, that has patient care that is geo-referenced as to where they pick them up, what time, where they take them? In Colombia, presently, we are not doing this in a comprehensive manner. The larger pre-hospital system that we have, which is Bogota's, had a geo-reference system, which at one point was implemented. We didn't continue it as it should have. But in Europe, there are some, and also in the U.S., that can do this geo-referencing. But in the rest of the world, it's very hard from the organizational point of view, because we do know that there are elements that would allow us to do this. And there's a question from the internet. What would you recommend for hypotension, pre-hospital hypotension, possible femur fracture? When would you prescribe vasopressors? Well, as I said before, using vasopressors is one of the things that we have to have very clear in our mind. On a pre-hospital level, you can only do it when you have teams with many resources that allow you to have the strict control that you would need for an infusion pump, control it adequately so that there are no problems. Some teams do it. We know there are critical care teams that can transfer patients in conditions that are very similar to what an ICU would offer. In these cases, you can do vasopressors perfectly well when you know that the volume is not the problem. We mentioned it yesterday with Dr. Ferrada, how there are already pre-hospital teams that are doing trauma ecography, and you can analyze the vena cava to know if the problem is in volume or not, so that you can decide whether to use vasopressors or not. The more resources that we have to monitor the patient and know what's going on will allow us to make an advanced use of medication. If we are in an environment where we can't know whether the resuscitation has been adequate or not, if we can only do a very superficial evaluation, sometimes it would be risky to begin using vasopressors without having done a correct evaluation as to volume. So you have to take those factors into consideration. What's the evidence in the use of hypertonic solutions in patients with shock? Well, the evidence is very low right now, very few observational studies. They really don't have an appropriate methodology yet. A lot of what's being done right now is being done in basic sciences, in animal models. So there are a lot of case reports. There are a series of cases, but there is no study that at present has demonstrated utility. And this opens the door for many of us here that are interested in trauma management can think of the possibility of doing a greater randomized trial to determine how important this type of intervention would be.
In the hospital itself, for a patient with traumatic spinal cord injury, sometimes the neurosurgeons want the map to be greater than 90. And we find that in our civilian trauma centers in the United States, this takes up a lot of resources with them being in the ICU for many, many days. So we question the data, and we were just wondering, how is it done in your country in Colombia?
Lo manejan en su país, en Colombia. Well, this topic of mid-level arterial pressure, it should be 3. There isn't much evidence in this regard. What we always try to ensure is that we have systolic pressure above 90. If the systolic is above 90, then we could guarantee that the management can be appropriate. Now, inside the hospital, as Dr. mentioned, in ICU or even during surgery, the idea is to guarantee the perfusion. I think the limit of 85 or 90 isn't something that's quite clear at present. What is clear is that we have to at least maintain systolic pressure above 90 for management. And what's going to change the prognosis is not resuscitation. At that moment in the hospital, what's going to change the prognosis is whether the patient needs early surgery to do it at an early stage so that we can correct the fact that the medulla not be compressed so that we can have adequate outcomes for the patient. There are 2 very large studies that have demonstrated that early intervention most likely has a better outcome, and of all the different types of surgery that can be done, the one that is most helpful to improve the outcome is posterior decompression of the spinal cord. It's not integral fixation, front, back, but the decompression in the first hours. And then after that, you can do a complete correction of the injury, including fixation, anterior fixation, etc.
Well, thank you for that great talk. We are a few minutes ahead of schedule, so we're going to take our break. And for the internet audience, we will be back at 3:30 sharp in order to conclude with our last session. Thank you very much for your attendance.